Hello, my name is Mohammed Ansari. My supervisor is Dr. Ashley Harris, and my project is using quantitative susceptibility mapping to understand persistent post-concussion symptoms. Before we begin to talk about persistent post-concussion symptoms, we must first understand what a concussion is. A concussion or maltraumatic brain injury is an alteration of brain function as a result of head injury. Following MTBI, various changes occur in brain white matter due to nowadays practice, such as demyelination and further the accumulation of iron and calcium. 200,000 concussions occur annually in Canada, and therefore it is imperative to address this issue. When it comes to the recovery time from concussions, most individuals are asymptomatic within a period of a maximum of 3 months from the time of injury. However, the persistence of symptoms beyond this period is referred to as persistent post-concussion symptoms. These symptoms fall into three major domains. The first of which is cognitive symptoms, which include decreased memory and attention. The second domain are somatic symptoms, which include dizziness and headaches. The third domain are affective complaints in which people have depression and/or anxiety. The means through which we assess patients in our study is the method called quantitative susceptibility mapping, or QSM. QSM measures magnetic susceptibility, an intrinsic quality every material has, and describes the way a material responds to a magnetic field. In QSM, we measure relative to water. Materials which increase the magnetic field upon being placed in one are referred to as being paramagnetic, and they have a positive susceptibility. Materials which decrease the magnetic field upon being placed in one are called diamagnetic. As mentioned earlier, MTBIs cause the influx of iron and the influx of calcium, called calcifications. As observed in this diagram, calcifications are diamagnetic and iron accumulation is paramagnetic. When it comes to the case of myelin, it is inherently diamagnetic, and therefore demyelination, the breakdown of myelin, which occurs as a result of MTBI, causes this region to become more paramagnetic. These post-MTBI changes can be measured using QSM, giving us a purpose to use it in our study. Here's a flowchart of our QSM model. We took a raw QSM image and we processed it to a masked image in which errors were omitted. And we finally further processed to get our final image, which looks like this. As you can see, there are different colored areas in the brain. The darker regions are diamagnetic and the lighter regions are paramagnetic. When it came to selecting regions of interest in our study, we referred to previous literature. A study which observed the brains of patients in a short time frame post-concussion found that there was an increase in magnetic susceptibility in their global white matter analysis. This was also seen in the superior longitudinal fasciculus, the cingulum, the inferior longitudinal fasciculus, the anterior thalamic radiation, the inferior frontal occipital fasciculus, and the forceps minor. Since these same symptoms carry on into PPCS, we anticipate to see the same changes as well. For our study, we had a total of 49 participants, in which we had 21 patients and 28 controls. For our QSM acquisition, we used standardized acquisition. And we further also had some clinical questionnaires to make correlations between symptom burden and our QSM data. These were the Rivermead Post-Concussion Symptom Questionnaire, RPQ, the Post-Concussion Syndrome Checklist, the Dizziness Handicap Inventory, the Quality of Life After Brain Injury Scale, and the Headache Impact Test. So the first result we had from our QSM data was that we found a significant difference between patients and controls in the inferior frontal occipital fasciculus, and this was through our t-test. Patients had a significantly lower magnetic susceptibility in this region, with a p-value of 0.01. Going back to the role that the IFF plays in the brain, this makes sense, as this white matter tract is involved in attention, affective behavior, and further serves as an executive control network. Damage to this region would lead to the impairment of these functions, something we see in PPCS. Further, the decrease in susceptibility may be attributed to calcification, as we know it to be a post-MTBI process and also to be diamagnetic. Another result we found in our data was that there was a significant positive and linear correlation between our QSM values and our RPQ3 value. The RPQ3 value is the sum of the scores of the first 3 questions of the Rivermead Post-Concussion Symptom Questionnaire, and these questions address somatic symptoms. The higher score is, the worse your symptoms are. We found that the worse your symptoms were, the higher magnetic susceptibility you had in the ATR. Going back to the role this plays in the brain, it's involved in complex behaviors, executive functions, and further has an emotional role in the brain as well. This is not what we found from our data. We found that there was a correlation between this and pain-related symptoms, and therefore it may show that this region may be associated with pain. So as a conclusion, patients with PPCS have significantly lower susceptibility in the inferior frontal occipital fasciculus compared to healthy controls. Patients with worse symptoms had higher susceptibilities in the anterior thalamic radiation, and QSM is a novel technique which will bring more knowledge about brain differences in PPCS with further research.